Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb.
Hello and welcome to the In the Thick of It podcast. I'm Dr. Betty Raman, and today we're diving into one of the most important questions in hypertrophic cardiomyopathy care. What difference does specialized expert-led care actually make? To help us answer this, I'm joined by someone who has set the benchmark of excellence in hypertrophic cardiomyopathy care. Dr. Srihari Naidu, who likes to be called Hari, is a well-renowned HCM specialist, director of the Hypertrophic Cardiomyopathy Medical Center at Westchester Medical Center, and a major architect of modern HCM guidelines and management strategies. If you've ever read about contemporary management of LVOT obstruction or septal reduction therapy, you've read his work. Hari, thank you so much for joining us today. Perhaps I'll start by asking, from your perspective, what defines a true HCM center of excellence? Is it the people? Is it its infrastructure, the patients, or the culture?
Yeah, my sense of this has evolved over the years. As you mentioned, I've been doing this for 20 years, and I think that, or more than 20 years, and I think initially I thought very structurally about this, which is that you need to have all the facets of a robust program. You have to have expert imaging, echo, MRI. You need to have great surgeons, alcohol ablation, all these things. And I think early in your career, you feel that if you have all these checklists of things that you need, that's enough. But I actually have felt very strongly that it's more than that. It is the people. And what I mean by that is that if you look at it from our standpoint, what we want to give patients, yes, we want to have all these expert therapies. But from a patient standpoint, it's totally different. They do want those. They trust that that's there. But what they really want is a home. They really want to find a place where they can come to and feel that they no longer have to be the expert at their disease. They no longer have to be the one in charge of making sure they get the appropriate diagnosis and care and treatment in an expedited fashion. They want to unload those things. So my philosophy now of a true center of excellence is one that takes over that responsibility for patients. And also by doing that is giving them all the appropriate diagnostic and imaging and treatment modalities that are individualized for their care. So there's a lot in there. What that really means is that you have a pattern recognition and an understanding of the variety of patients that come through with HCM, that you can individualize their care for the subset that they need based on your experience on what that kind of patient and that trajectory likely needs now and into the future. And so what does it mean? It means you need to have a lot of experience, which obviously you can't buy, but certainly over time you can commit to it over time. So number one, you have to have a champion and somebody who is passionate about this over 5, 10, 15, 20 years, make a career out of it. Not a side career, but it has to be your main career, number one. Number two, that person then has to make sure that you do have all the facets of diagnosis and treatment. So what it means is each of those components need to feel that they have the expertise and the experience to be able to do a really high quality approach to the diagnosis and management of the disease. So now it really is a combination of, I got you. Once you're in the program, then we can take care of it. We can understand your disease state and we can make sure you get the appropriate test that you need and move you in an expedited way to treatment. The way I look at it is that when patients come in, they enter this conveyor belt. They're not feeling well, or they're concerned, or they're stressed out about their disease state, their future and whatnot. And depending on where they're at, they may need expedited care to get them feeling better, breathing better. They may need expedited care to get their risk assessment up to speed and their risk of sudden cardiac arrest down, or they may just need expedited care to feel at peace with their disease for them and their family. And so depending on those trajectories, I really target it a little differently. But a center of excellence should be able to understand what the patient needs at that moment, and then add into that what we know we need to prioritize for them, for their immediate future and their long-term future. And those things should overlap in a way to expedite within the first 3 months to get them several steps forward.
Yeah, absolutely. No, you're absolutely right about ensuring we understand the needs of our patients and tailor our management as well as the care for patients. So I'd just like to sort of talk about diagnosis of this condition. Where do you think specialized care has a role in this particularly with the ever-expanding list of differentials that are coming our way with, identifying
Yeah.
people with hypertrophy.
Yeah, I think this has also evolved in that I think we went through stages where it was so diagnosed that the vast majority of the patients that came through were true HCM that were just missed for many, many years. Now that they're sending more and more of these patients, I think we have to be more and more careful that there may be phenocopies that are now in there and we're overcalling HCM. Now, not by a lot, but I think that by some. So I think that now we have to add in MRI, we have to add in PYP scanning, we have to add in genetic testing, and we have to educate ourselves a little bit more about these nuances where we could be missing amyloid or sarcoid or Fabry's disease. Now, the truth is, vast majority of the time when you miss these things, you're not making a huge mistake for some time, but it's important to get on the right track right away, as much as early as possible. So I do think that there should be protocols to make sure that at least some of these tests are more routinely done, and that the people doing them are really trying to clue us back to maybe looking at a differential diagnosis in those patients.
Yes. And to that list, I'd also like to add mitochondrial HCM, which, can be missed even with routine genetic screening. And yet there are specific mitochondrial cardiomyopathies that really limit themselves to cardiac manifestations and don't have the other extra cardiac neurological manifestations. So you're absolutely right. There are a range of differentials to consider, and certainly imaging, MRI in particular, has really helped in identifying those difficult to view regions in the heart, and more
Yes.
precisely measuring wall thickness, for instance.
Well, I think we're missing wall thickness. We've gotten much better at with MRI, but now the apical aneurysms, the percent of
Absolutely.
scar. I think we have to evolve in terms of how accurate we are about scar quantification. I think
Yes.
understanding mixed scar patterns between ischemia and previous myocarditis, for
Yes.
example. And I think some of these things are going to evolve as the MRI field evolves. But I think a lot of standardization has to happen. I've seen a lot of patients who come with a lot of scar, and it all has to do, and then we redo it here with our imagers, and the scar burden seems less. And so I think it raises a little bit of red flag that maybe there needs to be more expertise there or more standardization in that, because we're making a lot of decisions based on scar burden these days as well.
Absolutely. And on the topic of scar burden, so sudden cardiac death risk stratification is quite an important step in the care and management of our patients. Do you think specialized healthcare centers make a difference in the way we assess risk compared to, say, community cardiology settings?
Yeah. I think absolutely. I think the community cardiology setting typically overestimates the sudden cardiac arrest risk. And I think part of that is out of historical fear and how we describe this disease as the most common cause of sudden cardiac arrest. It doesn't mean it's a very common cause of sudden cardiac arrest. It just means that it's the most common amongst the ones who do have sudden cardiac arrest. But I think because of that fear, there was a lot of, in my opinion, inappropriate or overexuberant ICD implantation for decades in this country. That was partly that patients were sent first to electrophysiologists, and it's no offense. I'm an interventional cardiologist, and if you send patient first to an interventional cardiologist, you're more likely to get a stent than if you're not sent to an interventional cardiologist first for angina, for example. So it's similar for HCM. What we've done by having centers of excellence and champions is taking them and made them more the consultant. And so I think when they come to an HCM center, we typically understand that the overall risk is still relatively low, and we're looking at relative risk increase compared to the overall population of HCM patients. And there are ways to risk calculate this in a more objective fashion. As you know, you're in the UK, they do it a little bit differently in the UK with a calculator, left atrium and gradients, and versus in the United States, where we don't use some of those, where we use a little bit of scar burden as well, somewhat, but then more of the traditional risk factors. The truth is, the way we do it at our center is we do the risk calculator and we do the traditional way with the HCM guidelines, and then we have a conversation with patients. And patients are allowed to have their own overlay of what they consider appropriate risk, especially because you're putting in a permanent implant. So we have patients, most of the time they follow our recommendations about a defibrillator or not. However, I think it's an open conversation. This is where shared decision making comes into play. And it's not unreasonable to hold off or do intermediate levels of care, such as loop recorders and more watchful waiting in patients who are on the fence. And that's where a center of excellence comes in, which is that there's more nuance to this. There's more shared decision making. Now, that being said, if we feel the patient has a very high risk, I think that's also where the expertise comes in, and we can say, look, we see a lot of patients like this. This is what we've had. This is what we truly believe in you. Some patients are on the fence, and there's a risk that we can accept. You're not that patient. And that comes, that discussion is stronger out of a center of excellence that sees thousands of patients than it would be at a place that doesn't have that type of experience.
Absolutely. And we have multidisciplinary meetings on a weekly basis where we discuss cases with experts who've managed patients for years. And it really helps having a sounding board to talk about, cases and the complexity of each, each person in there.
Yeah, and the heart team is important because when you have a center, you have multiple people. You have the champion, you have a couple different EP people, and it can go back and forth. We may know the patient better in terms of their wishes and the family and these things. And so our electrophysiologist will do the discussion, and then the patient will come back to me. I'll look at their note and we'll discuss it again. And I can either say, I am in agreement, or you can go either way on this. And I think that ultimately you want patients to come up with where they're accepting this, because as you and I know, there are risks to defibrillators. And in fact, those risks are higher in the HCM population, and especially in the young HCM population. There's more lead fractures. There's definitely more T-wave oversensing. There's more ICD discharges that are inappropriate than appropriate in some of these patients. There's more AFib. So a lot of these things cause problems. And of course, every 10 years, you have to have battery change and things like that. So because of the accumulated risk on this population, it's very important to not just look at the risk of sudden cardiac arrest and the mitigation of that risk, but the lifetime accrual risk of all these other potential complications depending on the age of the patient. And that's where having the experience really comes into play, rather than say, put defibrillators in everybody because obviously they'll save some deaths, but at what risk is unclear.
Yes. Now let's talk about obstructive HCM and its management. We know that it varies across centers. How do you think specialized centers play a role, particularly in, the outcomes of procedures like septal reduction therapy and ablation, for instance?
Yeah, I think this is something that I spent a lot of time on because I came at HCM initially as an alcohol ablation performer, proceduralist, and then I gravitated towards really loving the disease process and accumulating patients, and that just being one area that I can also do for them. But I think that as I've seen the field evolve, for a long time, as you know, there was this debate between once you get past beta blockers, should you even use Norpace and whatnot, or should you just go straight to septal reduction therapies? And over the years, because of the robustness of the data, the guidelines have gone more and more towards go right to ablation or septal myectomy in appropriate patients, especially if you're at a place that has high volume, low risk. Now, in the meantime, the cardiac myosin inhibitors have come up. And so now there's more options to do some of this earlier. Even though all of them are class 1 indications, I will tell you at our institution, most patients start out with cardiac myosin inhibitors if they're good candidates for that. And then either if they're very young, they may move on to myectomy. If they're older, they may move on to alcohol ablation. And that's not just because of age and frailty, but rather because of the anatomy. The older patients tend to have the more focal septal bulge that's very conducive to alcohol ablation. If you take a step back, though, what I just said there is that we have all the options. And I think one of the challenges, just like if you have a place that just does coronary bypass grafting, and for many years, some places just did coronary bypass grafting, and there was this little thing called PCI or angioplasty that was annoying, and people didn't believe in it for a long time. And so you can make the argument that every single patient could get CABG with coronary disease, even if it's single vessel disease. And believe me, some people made that argument back in the day. So one of the concerns I have is that even though myectomy can be done in every patient, the real question is, should it be done? And I would argue that it should not be done in patients who would do just as well or better with cardiac myosin inhibitors and just as well or better with alcohol ablation. And the reason I mention this is because I think that we tend to lump alcohol ablation and myectomy in the same bucket, whereas as septal reduction therapies, and that's true, but it makes the false implication that you can have one and not the other. And this goes for, I don't think that a place should just do alcohol ablation and not have the option for surgery, because then you'll be doing inappropriate ablations on patients who probably won't be as effective as surgery. And on the flip side, if you do surgery on the patients who should get alcohol ablation, you're going to take a lot of risk for these patients where ablation has lower risk with the exception of the pacemaker risk. And so I think it's important, just like we talk about nuanced care for patients for everything else, for these very intense therapies, we need to be honest with what we can do for patients. And if we can't do the appropriate procedure for them, what we think is ideal for them, that should be sent to a place that can really do that. And so I'm lucky to be in New York, where people do send me just the alcohol ablation. I send them back the patient after that because they recognize that they have someone in the area that can do a really great alcohol ablation. And when I was at my previous hospital, we weren't doing myectomies. And so I would send my myectomies to NYU at the time, Dr. Swistel. And so I am doing what I always did, which is that if a patient needs myectomy, I'm not going to do an alcohol ablation. They're going to get the myectomy by somebody that I trust, and that patient will come back to me and I'll keep following them. And I'd like to encourage that to happen all over the country as long as these procedures are required. Now, maybe they won't be in the future if myosin inhibitors get better and better. But as long as they are for a subset right now, I do think that everybody should have all of these options and should be honest with themselves about whether the center can perform all these things.
That's very clear. Thank you. That was really interesting to hear. Just shifting focus now to genetics and how critical embedded genetics expertise is, particularly for patient management, and how specialized centers might be able to offer this, which won't necessarily be available for people in the community.
Yeah, I think genetics is something that scares patients because, in general, people don't want to believe that whatever they have is A, something that they couldn't control for some reason, and B, that they're now responsible for the rest of their family. These are heavy burdens for patients and families to digest. So I think centers of excellence can really help by having genetic counselors and people who take the time to really talk about it. What is genetic testing? It's a fancy word and it's scary for a lot of people. What is it? What are we talking about? Is it a blood test? Is it a buccal swab? How long does it take to come back? What are the implications for my health insurance, my life insurance? How does it work? Why do I need genetic testing if I already have the disease? You're telling me I already have the disease. How does that help? And to add some confusion on top of that, the results come back negative or positive or indeterminate in our VUS. And negative, oftentimes, I would say the vast majority of patients that see negative, unless you preemptively tell them about this, think they never have to see you again. They think you were wrong, and that because they don't have the gene, obviously they don't have the disease, and then they disappear.
Yes.
So I think genetic testing is very complicated because you need someone who will spend the time to have them sit down and explain all these things, despite what education or understanding healthcare literacy that they have. They need to understand what it is. And then beyond that, obviously, it opens the door to, not misclassifying the disease as something else, getting appropriate treatment for hemochromatosis or Fabry or something else, and also pulling in all the family members, whether or not it's positive or negative, so that it becomes a family disease. So the way I explain it to my patients is that, if you had breast cancer, you'd want to know if you have the gene in your family so everybody in your family can get tested who is at risk and get earlier screening. And so genetic testing really helps people understand that doesn't mean you have the disease. It means that you're now at risk. But if you take care of it, you can lead a healthy, normal life. And I do tell my patients that the chances of living a normal life expectancy once you're in a center of excellence is the same as everybody else. So you're fine now. You don't need to worry about it. You're with us. You're with a center of excellence. We're going to handle everything, and you go about your life and do everything you need to do, because no matter what hurdle comes up, we can handle it. And this goes back to the initial statement, which is that what is a center of excellence? It's somebody. It's a place that can tell you that we got this. We can handle everything that happens in your HCM life, whether it's nothing right now or more things in the future. But you go on and do your thing. We're going to handle everything that happens until you live a normal life expectancy like everybody else.
Yes, no, absolutely. I think, that's clearly what defines the center of excellence. Do you think that some patients, why do you think some patients may still not be referred to specialist care by their general cardiologist? What are the barriers?
Yeah, that's a great question. The issue is, one of the issues, we don't really know what that number is. I'm not even sure. We tend to believe that everybody's coming to us because we see all the patients coming to us. We see thousands of or hundreds of patients coming, dozens every couple of weeks or months, and we feel that everybody's sending, but we don't know. One hesitancy, I would say, is that there's still probably generations of community doctors who feel that most of HCM care is beta blockers and defibrillators as needed. And the challenge of that is that they're not completely wrong in that if you don't care too much about quality of life, you're probably doing okay. Most of them will struggle. They may not have all of the things that get them the most improvement in their symptoms, but you're probably doing okay in terms of preventing sudden cardiac arrest, and they'll live a relatively normal life expectancy. So there's a hesitation that they're not doing it as well and the incremental benefit you get. So I will acknowledge that there is some hesitation to that, number one. Number two is that distance. I think some patients don't want to feel like they have to have two cardiologists, and the second one is farther away for something that they don't feel. A lot of HCM care is prevention, meaning that if you come to me and you're feeling well, I can tell you that whether you have a higher risk of AFib, whether you have a higher risk of congestion, I can tell you based on what your phenotype is right now, what do we have to look forward to or not look forward to, because this is the pattern, and really help you deal with this 3-year lifespan. And so many people may not find the value in that until they show up to it. So we get a lot of people who, by the time they come, they're very appreciative of the visit, but before coming, they have no idea what the value of that visit is. So one of the things that I think is absolutely pivotal is having an HCM coordinator who answers the phone, who can explain why your doctor wants you to come to a specialized center. And I think that initial pitch, recognition of the person not understanding, is very helpful to draw them in, by saying that this is specialized. The echo is much more intense in terms of how we do it. We may find things that can help your trajectory and your clinical situation over time, the family aspects of it. And I think and the nuance to taking care of these diseases over a lifetime. So some of the hurdle is the referring, but I think a larger hurdle is the patient. They're not sure the value added. They don't want to have a disease that's rare. So they're going to be some avoidant behavior. And the distance. We have patients who don't want to come an hour, yet I have people who fly 5 hours. So it tells you the difference between what hurdles some people, will take because they understand it more, and the hurdles that some people won't take at all because they don't understand it. And so those hurdles, I think, are largely due to patient not understanding. And it's up to the referring cardiologist to really say that you need to see this person and you'll be happy once you do. But it may be hard for them to explain why, other than that I don't see a lot of these patients, and so I'd like to get an expert involved.
Yeah, no, that's true. No, I was actually thinking, if a clinician who is listening to this podcast wanted to start a regional HCM service, what are the elements that we would ask them to include to make it a
Yeah. Yeah,
service?
I mean, I started and talking about all these things, and I don't want this to seem arrogant or that, because obviously I just started as someone who didn't know anything about HCM, and I learned more things over time. So
Mm.
everybody can do this. Every cardiologist can do this as long as they have an interest in it and want to see more and more patients, and then experience plus expertise, and technical and knowledge from reading makes you an expert. So I do think anybody can do it as long as they, hang a shingle and say, I want to see these patients. I'm going to read up on these things, an
And you have a
HCM in more detail.
multidisciplinary team.
You start with start with echo. Echo has
Mm.
to be, your techs have to really understand HCM protocols, and the diagnosis has to be key in terms of physiology, who's obstructive, who's not. Then I think the next angle on top of that would be MRI, but that can be done at any facility. You just have to find the facility that is doing a lot of HCM patients and seems to be good at quantification and turnaround times. And then beyond that, I would start with the medications and start understanding how to do CMIs and really make sure that the echoes are done well and routinely, and you're having a high fidelity of that. And then from there, you add on facilities that can
Genetic
do the other,
counselors.
yeah, they can generate counselors, the other procedures. And the AHA is also thinking about doing certification now, which means that you can have places that are more community hospitals, individual physicians, but then the robust comprehensive centers. But in between those things are people who have a passion and have an increasing volume of patients, probably initially with the CMIs, but then can virtually put together the facets that we're doing at these major centers. At least the echo, the MRI, one EP person, and probably one cath person to sort of figure out the hemodynamics and physiology if needed. And then from there, you can always send to the big centers for surgery or alcohol ablation, because patients are fine going to big places for those procedures. And there's really no excuses to be able to send to, if they want to go far away, Mayo Clinic or Cleveland Clinic or Boston or our center for surgery, or for alcohol ablation. There's ways to figure out what places are doing good volume of these. And I think if you can do 90% in your regional area, I don't think patients have a problem going further out for the major procedures.
Yeah. And so I might end today's session by asking, if you had to summarize in one line why specialized HCM care matters, what would you say?
I would say HCM specialized care matters because doing the right thing for the patient matters. And it also gets them a higher quality of life and quantity of life over time. And so if we're going to be true to ourselves, a rare disease that requires a lot of invasive and non-invasive testing has to be housed in a way that patients can get that done. And I think it's very hard to do that in piecemeal.
Absolutely. The right expertise can mean, the difference between a misdiagnosis or missed risk.
I mean, the number one thing patients say is that, why did no one tell me this before? They've been oftentimes living with some symptoms, and we know that it doesn't grow this fast. In middle age, it's not growing a millimeter, every 6 months, right? So they've been living with this for usually 10, 15, 20 years by the time they come to my office. And it's just been missed for so long. And the confluence of the same disease process and their declining conditioning causes symptoms at some point. And it kind of outstrips what their heart can do, and then they get symptomatic. And so by that time, there had been imaging in all these patients, and it wasn't picked up. So comprehensive centers typically pick this up. And we know that here because I get routine consults from the echo lab on random patients admitted to this hospital for other things that have HCM. And by the way, they're here for a foot thing, but can you go see them for HCM? And that tells you that these patients are all there. And our echo lab will find it and tell us. Whereas I think the echo labs that are not used to seeing HCM are getting the echoes, and they're just finding EF and MR. They're missing the HCM over years. But I think the future is that all these should find it because echo techs should be trained more robustly. They should be looking for HCM more. The protocol should be ingrained into the routine echoes, just like AS and whatnot. So that way you'll just find them. And then once you find them on routine echoes, you catch them earlier. And if you catch them earlier, guess what? We have less heart failure, less sudden cardiac arrest, less burnt out HCM, less transplants, and more kids protected. So I think that's where the future needs to be.
Yes, absolutely. Well, Hari, thank you so much for such a thoughtful and practical discussion. You've really helped bring clarity to this area that, we often find overwhelming sometimes, and patients might find it overwhelming. So what you've shared to us really reinforces a very simple message, and that is specialized care really does save time, reduces uncertainty, and genuinely changes outcomes for patients. So with that, I'd like to say thank you to all for listening. It's been wonderful to have Dr. Naidu, an expert in the field, share his insights. Thank you.
Thank you, Betty, for this. Thank you.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.